Hello, welcome to today's webinar, Smart Scaling, Enhancing Your Practice and Patient Experience. My name's Mel Prebble, I'm your speaker today. I'm a dental therapist practicing in the United Kingdom. Thanks to Dentsply Sirona for their support with this presentation. So let's take a look at our aims and objectives. Firstly, we're going to consider how Cavitron technology enhances periodontal treatment outcomes and how this affects the patient experience and our practice. By the end of this presentation, you will understand the mechanisms of action by which ultrasonic instrumentation remove and disrupt exposits. Understand how adjustment in operational variables affects the treatment outcome, and we'll understand the factors that influence inset selection, be able to identify different tips, and outline the principles of clinical application. And we'll be able to consider tools available to enhance the patient experience. So what are the key considerations? When we perform periodontal therapy, there are many key considerations that affect the outcome. For example, the treatment plan. Do we have a diagnosis? Is the patient well informed? Has the plan been provided? And so on. As we move through today's presentation, we will look closely at tip selection to see how this impacts debridement success. We'll take a look at time management and patient comfort. This is what I would call the smart scaling method. This is based on efficiency and comfort. Ultrasonic scaling can quickly and effectively remove even the most tenacious calculus, which means the patient is in the chair for less time. And patient comfort. Patients experience less pressure and greater comfort during ultrasonic scaling procedures compared to hand scaling. And this creates what I would call a win-win. The more comfortable the patients are, the more likely they are to return. So we'll take a brief look now at power scalers. And here's some revision of power scalers. The technologies are broken down into the sonic here and the ultrasonic, which then has the subcategory piezoelectric and magnetostrictive. My chosen method of instrumentation is the magnetostrictive here, and that's the focus of this presentation. So how do magnetostrictive scalers work? Magnetostriction is defined as the changing of a material's physical dimension in response to changes in magnetization. In other words, a magnetostrictive material will change shape when it is subjected to a magnetic field. So in an instrument such as a power scaler, we have the electrical energy converted into magnetic energy, which creates the magnetostriction and the mechanical energy. So then the tip moves. So what you can see here is the handpiece containing the wire coils, which produces the magnetic field. The magnetic field causes the metal stack to elongate and stretch and return to normal length, which creates the vibrations that travel from the body to the tip. So here you can see the insert itself for a magnetostrictive insert. We have the tip, the nozzle, the connecting body, which is inside the nozzle, the seal, which we commonly know as the O-ring, and the stack. And what we can see here is that when the magnetic energy is created, it causes this elongation of the nickel stack, which creates the vibration. So looking closer now at the insert itself and how the energy vibrates through the tip, along the ultrasonic wave, there are points where no vibration occurs. This is called a nodal point. You can see these here as these yellow points on the diagram. Nodal points occur at different locations dependent on the tip design. Usually there is a nodal point between 2.2 and 4.4 millimeters from the point of the insert, and that's here. Therefore, when adapting the instrument for scaling, we must consider what aspects of the tip are in contact with the tooth, as a nodal point may be reached and can influence the instrumentation. We will cover this in a little bit more detail later on during the presentation. So what type of stroke do we create? We're creating an elliptical stroke with a magnetostrictive instrument. This means that all surfaces of the instrument are active. Let's take a closer look now at the mechanisms of action. We have 4 key mechanisms of action: the mechanical, irrigation, cavitation, and acoustic microstreaming. Looking now at mechanical action. The mechanical action results from the longitudinal sweeping motion and rapid movement of the tip. The speed of the tip movement ranges between 25 and 50,000 cycles per second, which is measured in kilohertz. In other words, with ultrasonic scaling, the tip is doing the work versus the clinician being the power behind manual scaling. Next, we have irrigation. The irrigation mechanism of action is the lavage effect created by the water supply, which is primarily needed to cool the heat generated from the rapid movement of the tip. And what you can see here is that irrigation will aid rinsing away endotoxin, flushing debris, and it also contributes to the other 2 modes of action, cavitation and microstreaming. Acoustic microstreaming. This occurs simultaneously with cavitation. The forceful flow of the cavitating fluid has the ability to debride beyond the surface actually touched by the tip, removing biofilm up to 0.5 millimeters distant from the area of contact. So looking at this diagram here, you can see the whirlpooling effect on the image here, and this enhances effectiveness beyond the surface of the tip. And this image shows the surface affected using a dry tip compared to when water is added. So this biophysical force enhances the mechanical action of the ultrasonic scaler, and this was documented by Walmsley in 1998. Finally, cavitation. So cavitation happens simultaneously with acoustic microstreaming, and it has the potential to be bactericidal. The phenomena of cavitation was first reported by Walmsley back in 1984. And the results when the water supply meets the vibrating tip and forms minute bubbles. The bubbles grow in size and then collapse inwards or implode, releasing a burst of energy. This burst of energy enhances biofilm removal and may have the potential to disrupt the cell walls of the bacteria. And this diagram here demonstrates the implosion of the bubbles. Looking at the operational variables, we have the frequency, the power, and the flow rate. The frequency is the number of back and forth strokes per second measured in kilohertz. The power adjusts the stroke length, which influences the amount of force and cavitation. And the flow rate adjusts the amount of water flowing through the handpiece and over the tip. So, as I mentioned, the power level determines the stroke length only. A rule of thumb is to use the lowest power necessary for the required task. And I would also say here, this diagram demonstrates the elliptical action. And as we change the power setting, we're changing this stroke length. It's also important at this point to consider tip wear and efficiency. So as our tip wears, not only do we encroach on that nodal point, but also we're affecting the stroke length. So a rule of thumb, lower power creates a shorter, less powerful stroke. And you can see that here with the analogy of a swing. And this is ideal for biofilm disruption and fine calculus deposits. And then a higher power, a longer, more powerful stroke is ideal for larger amounts of calculus and staining. And the water flow. The water flow cools the handpiece and the insert and the tip. It's essential for cavitation and acoustic streaming to occur. An adjustable flow rate allows the user to select optimal flow. And my top tip here is to insert the tip into a water-filled Sterimate before applying the power. This keeps the stack of your insert cool, so it creates longevity. So when setting up the Cavitron unit, I recommend that you set up on a low to medium power level, regardless of which power setting you will be using. At that low to medium power level, you can then adjust the water flow so that the droplets are generated at the tip, accompanied by a mist. The droplet of water needs to be available to the tip to produce whatever cavitation and microstreaming potential there is. What this means is when you boost to high power, the droplet atomizes, creating only a mist. The loss of potential cavitation and microstreaming effects in high power is not relevant, as cavitation and microstreaming do not enhance calculus removal. They enhance biofilm removal. So thinking about our treatment outcomes, what are the outcomes that we'd like to achieve? Our overall aim is successful debridement, and there are many key factors associated with that. Ergonomics. How does using an instrument affect us? How does this affect our patient? And the ability to contact the root surface affects successful debridement. And efficacy and efficiency of deposit removal affects successful debridement. And what effects are we having on the root surface itself? And finally, how comfortable is our patient during the procedure? So smart choices in insert selection affect successful debridement. So now we're going to take a look at my chosen inserts and the general techniques that I would adopt. For biofilm and light calculus removal, the Cavitron Thin-Cert, which is this insert here, is 47% slimmer than the slimline version, which is the green tip that you can see here. This tip is aimed to provide access into difficult areas, and it also allows for greater tactile sensitivity. Because of its very thin Explorer-like insert tip, you can feel more. So it does enable you to instrument and then turn off your power, and you can feel as just like you're using an Explorer. For light and moderate deposits, we have the slimline range of inserts here. I use these for subgingival instrumentation and instrumentation of light to moderate calculus. And for heavy deposits, or what we used to traditionally call gross scaling, I would use the Powerline inserts, which you can see here are the blue inserts. And these are designed to remove heavier deposits. So looking closely now at the Powerline range of inserts, it's not a one-size-fits-all, as traditionally people would think. Many tips are used for different reasons. So within the Powerline range, we have 3 tips: the FSI 10, the 100, and the 1000. So by gross removal of deposits, I would be using these tips on a high power and a high water setting. And the number of zeros denoted here on the tip, on the insert I should say, denotes the number of bends in the shank, which allows for access in different areas. For example, the 3-curve shank of the triple bend design facilitates access to line angles and interproximal service. It's the most useful in the removal of tenacious calculus because of its mass compared to the number 10. It has a longer stroke length and therefore has greater energy distribution as it has coined edges. Looking then at the slimline range, which are the green inserts here, we have the left and the right and the straight inserts. The insert itself is 30% slimmer than the Powerline. This allows us to have access subgingivally where the tissues will allow, and it's designed to be used for light and moderate calculus, staining and biofilm. I would tend to use this on a lower power, lower water setting to obtain cavitation and acoustic microstreaming. We also have the right and left, which allow us to adapt around complex root anatomy, and I'll come on to that in a little bit more detail. So the slimmer tip allows for less tissue distension. So the curved tips. The curved inserts enhance adaptation of posterior root surfaces, concavities, linear depressions and furcations. By placing a curve in the active area of the tip, the stroke pattern is altered and the linear strokes produced by a piezo tip actually become more elliptical. So here you can notice a gap between the straight insert and the concave root surface of the molar. And then when we look at the adaptation of the curved tip here, that space is not evident. So now, thinking about the size and the shape of the toe of a traditional curette, you can see how a curved inset adapts onto and into furcations on molars. And again, we would use this on a low power, low water setting for finer, lighter deposit and biofilm disruption. We also have the Thinsert, and this tip is again 47% thinner than the Slimline. This, as I mentioned earlier, provides a tactile feel, so you can officially detect and remove calculus without transitioning between an explorer and your insert. It provides great access for difficult areas. I really like to use this insert around orthodontic fixed wire retainers. It's really useful to get into all of the little nooks and crannies. And it's excellent for biofilm disruption in maintenance patients. As I mentioned, it is designed for removal of light and moderate calculus and deplaquing. So to get maximum benefits, I like to use this on a low power, low water, although it can be used on any power level. So what other tools do we have available to enhance the patient experience? So thinking outside of the surgery, we can ask ourselves questions. Do we have protocols for meeting and greeting patients and welcoming them to the practice? Does that improve and enhance the experience? Are we up on our communication skills? Are we encouraging our staff members to practice within their full scope? So are our oral health educators delivering oral health education, and so on? And are the team being trained effectively in communication skills? What type of education materials do we have available to us? Are we using perhaps videos, posters, or demonstration models? YouTube is very useful to find dental education these days, and it's also easy for patients to come well informed. Are we utilising indices in practice to explain our findings? Are we spending time charting periodontal measurements and so on? Do we have access to intraoral or dental photography to help educate our patients? And have we considered things like protocols for treatment planning and gaining patient acceptance? And have we considered protocols for recording patient communications just to streamline the experience for the patient and improve their outcomes? So in order to grow our practice, it's about creating a win-win. Happy patients return. Happy patients recommend us to their friends. And our practice will grow with simple protocols in place. We'll see an increase in treatment uptake. For example, if we're using our indices, perhaps taking time to disclose patients and deliver dental education prior to instrumentation. We'll see a difference in sundry sales, for example, and job satisfaction. And referrals will increase. Happy patients will recommend their friends and so on. And again, patient accountability. If our patients take control of their overall health, this again, in turn, will help our practice grow because those patients will be willing to stick to their regime. And overall, most importantly, are our patients satisfied and are they comfortable? So patient comfort is crucial because a bad experience creates a negative experience, which means they're less likely to return. So enhancing the patient experience. Today's patients recognise the importance of regular continuing care dental visits to avoid potential problems before they begin. Even once a problem recurs, there are new medications such as sedation techniques and technological advances that more efficiently and with little and no discomfort. The reality of dental fear is depicted in the cycle here. Dental fear leads to delayed visits, increased problems, and symptom-driven treatment. And we unfortunately see this too often. Many patients arrive into our treatment room with advancing disease because they were simply too scared to come. And what tools can we use to break that cycle? How can we help patients feel more confident to return and overcome their fears and phobias? Something I like to use, and I use generally every day in practice, is a non-injectable called Orapix. It's indicated for adults who require localized anesthesia in periodontal pockets during scaling and root planing. So it's a mix of lidocaine and prilocaine that aids patient comfort for periodontal treatment. The way it's administered is you will select a sextant, and step one would be to apply the gel to the gingival margin and wait 30 seconds. You then can insert the blunt tip into the pocket and fill the pocket completely. Wait 30 seconds and then you can begin treatment in that sextant. I find that this alleviates the tenderness associated with inflamed tissue when we're working into pockets. I also find it very useful if patients are more anxious and I'm planning to perform a periodontal charting and they experience some tenderness. This tends to alleviate the symptoms for them. And finally, a common side effect of periodontal treatment is hypersensitivity. And I would recommend to consider using fluoride applications. The 5% sodium fluoride varnish can be applied to seal the dentine tubules. And it's very simple and effective to use after treatment. And the reason I love this is because it can be applied to a wet surface. So we don't have to necessarily isolate and dry the area for the varnish to be applied. So in conclusion, powered instruments provide a therapeutic value over and above hand instruments. To achieve maximum benefits, optimum technique is required. And definitive debridement can be achieved with the correct insert selection, access, and adaptation. Reduced effectiveness occurs with improper maintenance and operation of our equipment. So I've covered all of the material for this evening, and I'm willing now and happy to take any questions that you may have. So the first question is from Bruce. Are all of these products available in the USA? Yes, I believe they are, Bruce. If you log on to the Dentsply Sirona website, you can contact your dealer. You will be able to access availability. So the next question we have here is that I tend to see clinicians who only use the ultrasonic create burnish calculus. How can this be alleviated? So if we're looking at the action of the tip itself, and we're using the tip coronally to apically, we're tapping down onto a deposit, and we're using this insert selected for the job. So for example, large deposits, we would use a high power, high water on the power line insert, and that would alleviate that issue. So there is a question here, should we dry the tissues before applying Oroquix? No, you don't need to dry the tissues. Just apply the gel at the gingival margin first and wait for it to work, and then insert it into the pocket. You're working with crevicular fluid and so on, so a dry field is not relevant. I personally do tell the patients that it can taste bitter, and I use suction to take away the saliva. And we have another question here. Do I need a prescription from my dentist before I use fluoride varnish on a patient? So I can't speak for worldwide, but in the UK, we do have treatments planned for us and prescribed. So it can be that it is, although if you are working with direct access, then this particular varnish does not have to be prescribed. It's not a prescription-only medicine. Next question, any recommendations or suggestions on suction tips and ways to suction water while using the power scaler? So I would always use the manufacturer's guidelines of high volume aspiration, and I know that there are some aspiration tips available that are angled to help if you are working unaided, or ideally you may have an assistant to help with saliva evacuation. So there is a question here, if you turn the tip to the gingival, can you perform curettage? So no, the tip is not designed for you to perform curettage. It's designed for you to remove deposits and biofilm. So I think we've covered all of the questions coming in. So I do have a question here. In brief, do you have any comments on piezo versus ultrasonic? I don't have any comments. I am not a piezo user, although the key differences are that with the piezo, the action is more linear. So you have different sides or aspects of the tip that are active versus the magnetostrictive. So you have to be more technique sensitive to engage the working surfaces of the tip. So I think we've covered everything for this evening. Thank you for joining me for this webinar. Much appreciated.